Hi, thanks so much. And I'm Thanuja, and I'm going to talk about recognition and management of autism spectrum disorder, which is a very broad category and it's quite complex. So, my lecture is structured like this. It's what is autism and clinical features according to NICE guidelines, and how we would assess locally. And also, I will be touching the DSM-5 criteria and the management of autism. So, autism is basically a neurodivergence condition. So, there are so many other neurodivergent conditions which overlap with the clinical features. However, there are different specific features for each condition. So, what are these other neurodivergent condition? Dyspraxia, which is coordination difficulties. Tics, if it is very severe, we would call it Tourette syndrome. And ADHD, I think which all of you know. Dyslexia, where a child could have poor spelling, difficulties with reading, and also dyscalculia, it's basically difficulties with maths. So, ASD or the autism is a neurodevelopmental disorder typically diagnosed in childhood, and it's a lifelong condition. It's a spectrum. It varies from very mild to moderate and severe. Kanner first described autism in 1943 when he observed some children who were unable to form any relationships. However, autism was officially not recognized until 1980, and in 1980 it was recognized under DSM-3 criteria. It affects about 1% of child population, and boys have 4 times higher chances of having autism. And also girls tend to mask the symptoms. So they are usually diagnosed lately. However, the severe autistic children will be diagnosed at a young age. There are no diagnostic biomarkers or definite tests to diagnose autism. It is usually associated with lots of other comorbidities like ADHD, dyspraxia, sleep disorders. So, according to DSM-5 criteria, autism is described as there are two main parts. One is persistent deficits in social communications and social interactions across multiple contexts, and restricted repetitive patterns of behavior and interest or activities. So under social communication, there are three sub uh, groups or three different criteria, which is deficits in social emotional reciprocity. That means difficulties with emotions, conversation difficulties, non-verbal communication. That's we use lots of gestures, eye contact, facial expressions. So these children tend to lack these communications. And one of the main difficulties is difficulties in developing and maintaining and understanding the relationships. Under repetitive and restricted patterns, there are 4 categories. Stereotyped or repetitive motor movements. These are usually rocking, flapping, uh, or flickering of fingers. Insistence of sameness or inflexibility. This is again very much characterized in children with ASD. They don't like changes. They can't cope up with any changes. They don't like any new situations. Most of these children do have some highly restricted and fixated interests. That means obsessions. And also almost all the ASD children do have sensory difficulties. It could be hypersensitivity or hyperreactivity to any sensory input. So what causes ASD? None of the causes are None of the causes are 100% proved. However, definitely they have found that there is some relationship with genetics, and there is no definite any inheritance pattern. That means there is no autosomal recessive or autosomal dominant pattern. However, definitely genetics are contributing to ASD. If one family member is affected, there is very high chance that child may be having ASD. Other siblings may be having ASD. Or if the parents are affected, there is high chance that children could have ASD. And there have been huge advances made in genetics during past decades, especially during last 5 to 6 years. And microarray, whole genomic sequencing, copy number variants, and single nucleotide polymorphism. These are all genetic tests. And they have proved that there is definitely very strong relationship between ASD and genetics. And because of emergence of microarray, when you check children for microarray genetic test, you do find out microdeletions and microduplications. And some of the children who have learning disabilities and microdeletion of common microdeletion is 116p11.1, which could have associated ASD and ADHD. And most of the microdeletion syndromes do predispose the child to have neurodivergent conditions like ADHD and ASD. And there are certain syndromes like Fragile X, tuberous sclerosis, or Rett syndrome. And children who have these syndromes have higher chance of having autism. What are the other factors? There had been a Swedish study which proved that which is suggestive of advanced parental age, especially paternal age, can lead to ASD. Any other prenatal exposure like air pollution, pesticides, and the maternal factors like obesity, diabetes, and immune system disorders also could lead to ASD, or it could be a causative factor. Extreme prematurity and very low birth weight babies also can have ASD in the late life. And hypoxia at birth due to any condition like fetal distress, asphyxia, or any respiratory distress, a child could have ASD. So, how do they present? The clinical presentation. Clinical presentation is usually varies according to the age. And I am going through the NICE guideline presentation, and it's very briefly discussed here. So the spoken language is one of the main things which is used in communication. So the preschool children, preschool is usually under 5, that's before going to school. So they will present with speech and language delay. And also sometimes in autism, you can have speech regression. Child will start with speech at normal age, around 1 year, 2-3 words, and it improves around 2 years. The vocabulary expands during the second year of life. However, after about 2.5 years, child might lose those words and child might go back to 2-3 words. So that is possible in speech, ASD. And they do have some unusual spoken language, which could have some odd or flat intonation, and echolalia. Echolalia means repetition of words or phrases. Child might not speak, but they can have some learned phrases and keep on say the same word. They also sometimes just speech like vocalization, but these words, this speech doesn't have any sense. They just make some vocalization, and also tend to use single words rather than using sentences. When you go to primary school age, that's usually about 5 to 11 years, the speech has developed. Most of the children who have significant speech and delay with ASD are now diagnosed. So children who present during primary school age, even though they can speak, they are very, very reluctant to initiate the conversations. Even if someone starts a conversation with them, they would speak about their own interest and try to monopolize the conversation. It doesn't go two-way. They will have very monotonous tone, which is usually we call American accent. And they could be abrupt. And when they are speaking, they would not have a filter. They can make some rude comments like you're fat or ugly. Secondary school age, that's above 11 years, they will have the similar features as primary school age. So again, the main problem is communication in ASD. So how do they respond to others? Preschool age, poor response to name. If the child is called a name, they would not reply or they would not turn. There is reduced or absent social smiling. Usually the social smile comes around 6 weeks of age. And some of these children with ASD, usually severe ASD, their social smile is delayed. And they also do not recognize other people's emotions or social cues. They can have unusual negative response to the request. That means purposefully they just avoid answering or reacting to the any other people's request. These children could be less affectionate. Usually the little babies and children, they are very affectionate. They would love cuddles and hugging the parents or the siblings, but they could completely reject the cuddles. When they are present in primary school age, that's 5 to 11 years, or secondary school age, all those above features could be there, like lack of social smile, not understanding emotions and social cues. In addition, by this time, usually children do understand sarcasm, idioms which are age appropriate, and they tend to understand these idioms and the sarcasm very literally. For example, if you say you have to pull up your socks, that they think that you really need to pull up your own socks rather than the actual meaning. So they tend to take loads of things literally at this age, and they can get upset and can take the sarcasm personally. So other way of communication is interacting with others during preschool age. Usually children, if you see a little like toddlers, if you go to a play area or children come to their place, they would interact with other children. But these children tend to play alone and they don't imitate things. Most of the children, like 2.5, 3 years, they tend to imitate others, especially answering a phone or cuddling a baby. These children don't like imitating anything. And they don't enjoy any social events like birthday party. If they go to a birthday party, they would not join the rest of the children. They also could be aggressive or disruptive in places, and there is no joint attention. Joint attention is that if like adult shows a picture and sees, look, there is an elephant, they wouldn't look at you or join you with looking at the picture or understanding it. When they present at a primary school age, the interactions become more difficult. They can have an inappropriate approach, could be very aggressive towards their peers. When the child is greeted, like saying good morning or bye, they wouldn't react to you or even would not look at you. Some children could be overly formal. Sometimes like 7, 8 years of age, they would behave like adults, or could be over familiar, not understanding the personal space. There is also lack of awareness of socially accepted behavior. That means if you go to assembly or if you go to a supermarket, you know how to behave, but these children don't know, and they can just run around disturbing or could be disruptive. Again, they don't enjoy any social events like primary school. There are lots of school dramas, parties, discos, or any playdays with other children. They don't like joining these ones. When children go to secondary school, when they are a bit older, usually the normal children, they do have lots of friends. They have a friendship group, but these children tend to have very few friends or lack of friends. Even if they make friends, they find difficult to sustain the friendships. Their understanding of relationships is poor. They don't know what their role in relationships. These children could be friendly with either younger or older people, and lately they get socially isolated. All the other children are playing, but this child would isolate and just stays in a corner. They're usually by teenage, children do develop lots of interest like music or football, but these children tend to be, they don't have the same interest as the peer groups. So, in addition to above, there are so many other features. Reduced or absent imagination and pretend play. When they are very younger, like preschool and primary school, tend to have lots of imagination. They would say stories or pretend play, like again teacher, or tend to pretend a doctor. These children don't want to play like they would play just something, just one thing they would like. There could be some unusual or restricted or rigid and repetitive behaviors. And this is present in all ages. Rigidities are more apparent when they are becoming older, and they would not change, and they will stick to their own agenda, and they don't want to change their perception or their opinion as well. And these children tend to adhere to rules strictly. And these, when they get old, they would show very strong adherence to rules and wants fairness, and could lead to arguments when they are teenagers. The repetitive behaviors are usually stimming, like hand flapping, rocking. These are more common in younger children, but you could see them in older ones as well. Spinning, finger flicking, and also when older, these repetitive behaviors could affect daily activities. When you have ASD, you tend to follow very strict routines, can't cope with any changes or any new situations. So these children find very difficult to go on any holidays or school trips because it's a change. Even if you are picked up by a mother or father, if child is picked up by mother every day, father comes and pick up, they would get very upset. These upsets are becoming more and more difficult when they grow older, and they could have excessive emotional reaction to any changes. This can lead to more difficult when they are in secondary school. They can refuse to go to school and become dysfunctional. This is very common if the diagnosis has been missed or they were not diagnosed in primary school. When they go to high school, it's quite different environment than primary school. In primary school, it's just one teacher in class, but in secondary school, there are lots of different subjects taught by different teachers. They have to change the classrooms, so they find it very difficult. So, some of these children could have definite obsessions or specific interest. Again, these obsessions can vary from or go on phases. When they are very young, it's usually superheroes, dinosaurs, soft toys, or football. But when they grow old, it could be reading. And usually, when they read, they would prefer non-fiction or factual books than the stories. They also become very specific with these interests. When older age, they can get kind of addicted, especially video games. These children have poor gestures, poor eye contact, reduced gestures, and facial expressions. This is present in all ages. However, we have to remember child having ASD can have good eye contact, but that doesn't exclude ASD. So it is mainly going through all the features to diagnose the child. When they grow old, the emotional difficulties become very prominent, and during teenage, there is emergence of associated mental health difficulties. They find difficult to cope up with any physical and emotional changes which happens during adolescence and going through the puberty. Sensory difficulties are very common, and usually almost all the ASD children do have sensory difficulties. It could be loud, not liking loud sounds, so they wear ear defenders, not liking certain textures of clothes or food, usually prefer dry bland food, and also tend to eat the same thing. So in addition to all about features, primary school age and secondary school age children could have very unusual profile of skills. They can have lots of like coordination difficulties, both fine motor and gross motor. And some of them can have very in-depth knowledge in specific areas. This could be like space, history. They would know everything about history, and they would go on its search and read books. Their social and emotional development is much immature compared with their peers. They are easily led, naive, and tend to lack common sense and less independent than others. So, how are we going to diagnose autism? Because there is no definite biomarker or test, it should be a multidisciplinary assessment. And there are various ways of assessing ASD children. It could be that there are number of tools. So I'm just going to discuss how we assess in East Lancashire hospitals, our local pathway. So we get referrals from GPs, schools and course, that's special educational needs coordinating school, health visitors, speech and language therapist, SALT, and other medical professionals. So it's very important to get the parental consent before assessing the child, because if parents don't want to assess the child for ASD, we can't go ahead with the assessment. All preschool and primary school children will be seen by a pediatrician. And the secondary school children, if they are directly referred, they will be seen by a neurodevelopment practitioner. You have to take a very detailed history, especially regarding parental concerns and school concerns regarding the social skills and how it affects child's school progress. Birth history, again, very important to see whether there have been any hypoxic episode, whether child spent any time in neonatal intensive care, or anything affected during antenatal period. The family history, again, really important, whether there is anybody affected in ASD with ASD. And very detailed development history is also taken to see whether there had been any speech and language delay, how child's play skills are. And all preschool children that's under 5 will have a development assessment just to see which areas child is delayed. And it's not only assessing the development, you could see how child engages with it during the assessment. Child's eye contact, whether child interact with the person who is doing the development assessment, and also whether child would stick to his own agenda and do whatever he wants. And some of the very difficult children or severe ASD children, even it's difficult to even carry out a development assessment because they don't engage. So we have to gather lots of other information from other areas like school, because school is the best place to show your social communications. So most of the children who have ASD, they do struggle in school. So we do have some specific forms called Autism Spectrum Rating Scales, which is ASRS form, and a generic ASD form. I will just show you the forms. So this, the one on the left is the standard pen picture or ASD generic form. This is the best form for me, which gives the real flavor of child's social skills. So yeah, this is filled by the class teacher usually, and everything is there: social interaction, empathy, behavior changes, and obsessions. And on the right is the report of a ASRS form, where you get the social communications, very elevated. You can see unusual behaviors, peer socialization. So all the domains of DSM-5 criteria are there. So going back, this sometimes or most of the time, the school child is observed in school by a ASD practitioner or ASD specialist teacher. The preschool children, that's the children who are not going to school, either they are in a nursery or they may not go to nursery if they are very young. So they are observed either in the nursery or Child Development Center, which is called CDC. And this CDC usually are for the children with either developmental delay or children with difficulties with ASD. So they are observed for their interactions with other children, play skills, and also every child under 4 will be seen by a specialist health visitor who would visit home and see how child is interacting with their parents and also their play skills in the home. So this is the, when they come to see this is a different setup. So the child might not show the actual skills, but in the home it's a normal situation. So we carry out a specific social communication assessment. This is either by a speech and language therapist. That's mainly for the younger children. And also for older children, we carry out ADOS assessment. ADOS means Autism Direct Observation Schedule, which is an assessment which usually takes about 1 to 1.5 hours. The practitioner creates some artificial social situation, for example, like birthday party, and see how child respond to the situation. There are some mini artificial situations created in this assessment. You can see on the left side, that's the ADOS kit. And so there are loads of toys as well as other equipment which we use to assess the child. And they also ask child to imitate something. And there are a number of questions related mainly to the relationships, the social skills. And there is a scoring system. So usually cutoff for autism is 7, but it doesn't mean that you get 7 and you get ASD. You have to consider all the other difficulties from the other reports and then give the diagnosis. So when you get all the reports, we discuss child in the social communication disorder panel, which comprised or the chaired by a pediatrician or a clinical psychologist. Usually if child is under a pediatrician chairs a panel, and older children, it's sometimes clinical psychologist. So this panel is attended by the practitioner who carries out ADOS or the speech and language therapist assessment. Any other person who is involved with gathering information, they are invited to the panel, they can contribute. But we go through all the reports from everyone. Usually the parents and school staff members are not invited. So all the information from forms, various assessments and reports are discussed, and we compare it with DSM-5 criteria for autism and see whether a child fulfills the criteria to get the diagnosis of ASD. And the outcome is informed the parents within 6 weeks. So how do you diagnose? Diagnosis day is very important for the parents, especially in the UK. Currently, there is very long way to diagnose. It could be 2 years, 3 years. So according to DSM-5 criteria, we give the umbrella diagnosis of autism spectrum disorder. You may have heard of Asperger's, PDA subtypes, which used to be a diagnosis, but not anymore. We usually give autism spectrum disorder. So to get the diagnosis, as I told you earlier, there are two main areas in DSM-5 criteria for autism. A, social communication and interaction. B, restricted and repetitive patterns of behavior. So under social communications, there were 3 subgroups. So you have to fulfill, or you have to have difficulties within all 3 areas. And from the B, that's a restricted repetitive behaviors, out of 4 subgroups, you have to have difficulties within at least 2 groups to get the diagnosis. And when you are giving the diagnosis, it against mild to moderate. So there are level 1, 2, and 3, 3 being the severest form. You have to ensure that these difficulties, these social communications difficulties, are not explained by any learning disability child is having, because it's common to have learning disabilities with some children with ASD. So learning difficulties could restrict social communication, but these social communication difficulties are above and over the learning disabilities child is having. So there are 3 levels of autism, level 1, level 2, level 3. Level 1 is the mildest. They still require support. They have trouble understanding the following social rules, rigid and inflexible. Some stress during transitions, may benefit from therapy. Level 2, they require substantial support. Can have atypical social behaviors, high interest in specific topics, and this is very obvious now, noticeable distress, and may need school accommodations like reading help or social skills support within the school. Level 3 is the severest one. Usually these children are non-verbal and lots of repetitive behavior, significant behavioral difficulties and learning disabilities, and these children are usually in special schools. So why do we want to diagnose the ASD, and what is the impact on life? Usually these children have poor progression in both socially and academically in school, which has a major impact on their lives, and they will not reach their maximum potential. They get socially isolated. They can be bullied, and this is very common, and because they are a bit odd, so children, they tend to get bullied very much in mainstream schools. And there could be employment issues later in life, because you need your social communications and interactions, especially to do certain jobs. So it's very important to decide what kind of job if child has ASD, especially this is more mattered. Milder ones may be able to do, but still they can have difficulties. Some children, especially you are at level 2 or level 3, they will have difficulties in living independently. There could be lots of stress within the family, because one child is having ASD can have significant behavioral difficulties, and also because they are not independent or not progressing in school, this make the parents could be very much stressed. So how do you manage and support these children? So management program is usually to minimize the disruptive effects of autism on learning and maximizing the normative process. The treatment goals change according to age and development level as well as the severity. Treatment is usually focused on social language, adaptive skills. That means that if you don't like loud sounds, you can wear ear defenders, and also expand in the communication ability. So how are you going to expand the child's communication ability? Speech therapy is very important when they are younger. So all the children who have speech delay will be offered speech and language therapy. If there is significant speech delay and they are non-verbal, so they are offered signing, either Makathon signing or British language signing. PEX is picture exchange communication system. So there is a child recognize the language by looking at pictures. Care or the parents also use the pictures. For example, there is a picture with cup. So child will show the cup when he wants a drink. So usually these children carry all the pictures with them, and parents and carers also do have this. And there are loads of new computer-based technology to improve the communications. The behavior techniques and psychotherapy to manage the disruptive behaviors, sensory integration therapies, which is provided by the occupational therapist for sensory difficulties. The paramount important thing is the structured special education interventions, because the children, that is the time they study and educate. So if you don't provide the support and the intervention, especially at a younger age, child is not going to achieve. So furthermore, the addressing the comorbidities is very important. As ADHD, sleep and anxiety, you can use medications. There are severe behavioral difficulties with aggressiveness, then you can refer to a pediatric psychiatrist or pediatric learning disability psychiatrist. Behavior support is through CBT or clinical psychologist. Local or national support groups are also available. Investigations wise, we would just do genetic testing only if child has learning disability or dysmorphic features. If associated with seizures, we would go for EEGs. ASD is very complex. In conclusion, the diagnosis requires comprehensive assessment by behavior and medical experts, clinical evaluation, and the use of disorder-specific screening and diagnostic tools. The age of onset is early childhood, likely to have functional impairment throughout their lives. However, severity varies from relatively mild to profound. Impairments persist into adolescence and adulthood. Early diagnosis and evidence-based interventions will ensure better outcome and lesser functional impairment. And we have to remember that they all have strength. Thank you.